That's for the introduction. I'll try to get right into it without further delay. I know I have a number of slides, and I want to, respect your time. So I'm introducing the material entitled "Patient Blood Management: Tenets and Components in Establishing an Effective Program." I want to mention that the ones who attend my quarterly blood utilization review committee or transfusion medicine committee might be familiar with the patient blood management concept. I try to introduce some of the core components in the meeting, more of an introductory or just a incept into the physician's mind about this concept. I'm glad the medical students are in the audience. So this is one of the kind of stewardship programs that Joint Commission, AABB, which is the premier professional organization that transfusion medicine doctors, professionals are involved in, that we're focusing on for better patient care, right? Just like antimicrobial stewardship, other kind of stewardship programs. And so, if a hospital establishes a program, they can receive certification through the Joint Commission. And so it's kind of like a badge of honor for the hospital. And so it's not the question that do we need it, the question is, can we actually use, if we can't have a program, can we you actually adhere to some of the components, right? Because at the end of the day, it's for better patient care. So open your mind. I try, every slide is more or less intentional. Some of them may seem like fluff, a lot of words, but I'll try to be as punctual as possible. Okay, so two key objectives is to identify the key participants and stakeholders that is responsible for establishing and maintaining a PBM program. And then we're going to identify and explain the key components of a PBM program. No disclosures. So what is patient blood management? You're going to see this often, probably till the day you die, if you're looking out for it, right? So PBM, it's a multidisciplinary application or approach of evidence-based strategies that involve, I'm going to remove my mask, that involve the administration of blood products with the ultimate goal of affecting patient outcomes. So the PBM concept has been around maybe roughly 20 years. It started in Europe and say Australia. The concept gained more traction in the past 10, 15 years. In 2011, there was a survey that was conducted in roughly 1,300 hospitals in the US, and 30% of them responded that they offer some components of a PBM program, doesn't mean that they had established a program, it's just that they offer, and I'm guaranteed that we all already have some component already here, but we don't know, kind of what field to put it in. Several professional organizations have focused on PBM. AABB, this is the Association for Blood Banks, so association, now they changed the name for Association for Advancement of Biotherapies. That's the premier organization that I'm a part of. We focus on PBM, and if you go to our conferences, you'll hear many kind of across the nation, many new concepts in PBM and new initiatives. But like I say, also Joint Commission is very interested in kind of collaborating with AABB to kind of create standards. And so an effective PBM combines multiple approaches that expands patient care from pre-hospitalization and to even after discharge. In 2012, the American Board of Internal Medicine Foundation began compiling a list. This is probably not new to you guys. Medical tests, procedures that were thought to be overused or inappropriately used in the United States. Blood transfusions was one of those procedures. And of course, they created multiple choosing wisely campaigns to say how to intellectually and kind of engage these issues and try to, I guess, mitigate costs and make smart practices. Here is the kind of 5 choosing wisely steps that the American Board of Internal Medicine, in conjunction with AABB, want to pose to the physicians and patients to consider. So if anything that you take away from this presentation, consider these options. One is don't transfuse more units of blood than necessary. Number 2 is don't transfuse red cells or iron deficiency without hemodynamic instability. Number 3 is don't routinely use blood products to reverse warfarin. Number 4, don't perform serial blood counts on clinically stable patients. And number 5, don't transfuse O-negative blood except to O-negative patients in emergencies for women of childbearing potential with unknown blood type. I will maybe mention that last one is, it's not completely in your control. It's more or less for the blood bank as far as management. As you know, red cells, particularly plaque cells, are the universal, as far as red cells, it's a universal blood product, and we have only a certain amount in our inventory. And so that's kind of stewardship for the blood bank as far as inventory. So implementing the program, like I said, there is no standard some single approach for all the institutions. However, there are standards, right, to adhere to. If you want to, according to Joint Commission, have a certificate. Like I said, it all depends on the style of the hospital, the interests of the physicians. We need champions. So from all specialties. So I can't do it alone. So even me talking about PBM, and if we want to establish some kind of core, it will take interest of either attendings or medical students when you become residents or fellows or attendings, to kind of be interested in the blood bank and interested in stewardship to help to run the program. As you know, we have a transfusion medicine committee or blood utilization committee. This will be something separate outside of that. I try to introduce some of the core principles in the meeting just to kind of incept that, as I mentioned before. But in order to run a meeting, I would need some champions, and it will probably be someone outside of myself in the meeting. So probably from similar to the transfusion committee, so different specialties represented. Ideally, we would like to have somebody called a transfusion safety officer, which has a particular function and have more of a buy-in. They're like either a nurse or a physician, but typically it's a nurse, and they have more of a hands-on role of providing us with data, education, and monitoring and so forth. So they can be our kind of right-hand officer, so to speak. The PBM medical director, as I mentioned, doesn't have to be me. It can be anybody that takes interest. I know Johns Hopkins is like one of the, in Georgetown, one of the 2 institutions that I have to put on the platform, because they're really great representations of a PBM committee run by anesthesiologists, right, and the transfusion medicine doctor, more or less on sideline as a consultant. So what are the essentials for success of this program? So, we need hospital leadership as far as the CEO, senior management, departmental chairs, effective leadership, because it drives physicians and staff to participate in initiatives. So it's like a ripple effect, right? You see what's going on, in the program, and people want to become a part of it when there's action being taken. And of course, financial investments is not, especially when it comes down to the monitoring practice, which I'll talk about shortly. We may need, IT integration. Sometimes it's not as easy as it sounds, especially when you're part of a larger system, because it might, it might need some overhaul, so to speak, of the IT, especially when you're trying to establish, alert systems, when physicians are ordering blood, and I'll talk about that shortly. But because it definitely needs a top-down approach from the CEOs and for stakeholders. As I mentioned about transfusion committee, I said the PBM and transfusion committee, they're kind of supportive of one another, but they're 2 different categories. So once the committee has been formed, it should define the scope of activities it will address. Not all of the activities can be addressed at the same time. The goal is to achieve measurable and visible success. So as I mentioned, about the 30% of institutions having some components. So if we can establish that we do have components here at Queens, maybe we can just focus on those components and just keep it at that, and if you want to add another component, we can discuss that in future conversations. Like I said, we don't, if this is something you at Queens Hospital you're interested in, we don't have to have an official program. An official program, though, it would allow us to kind of gauge and monitor activities, but as I talk about the components, is probably the ultimate goal is to be focused on every component and see, whether improvements can be made. So like I said, attention is the most tangible aspects. Every institution is different, the layout is different, so we can see what's feasible. As I'll mention in the components, there are different ways we can monitor how the program is going, and we can also monitor practices, but like I said, sometimes it may require a system overhaul. All right, so let's go into the components. There are multiple components here. I kind of rushed a little bit because we started a little later. So this is the kind of focus of my talk, that there are a number of different components to have an effective PBM program. We'll go through each one of these. The first is transfusion triggers. So transfusion triggers is, they are based on the guidelines. I briefly looked at what we had in EPIC before this presentation, and I was looking at the indications in which special red cells are ordered, and it looks like, I was clicking on the drop down, it looks like the indications are very sound. So I'm very pleased to, that we're adhering to the guidelines. As you know, I didn't want to put any big data in this talk, but as you know, back in, say, 20 years ago, 10 years ago, there was and it's still today, there's a debate between liberal and restrictive strategy, like transfusion, a patient with 2 units versus 1, where they have a hemoglobin of 6.8, right? That's more or less, the goal for medical students and residents, just know if a patient is not acutely bleeding, you should just transfuse 1, right? And then check the hemoglobin or the platelet count, or if you want to give plasma, which I don't recommend, routinely. You want to check those values to see if the patient really needs another unit, unless they're, bleeding in the sense where you can't really, you can't monitor that. So it's not really a debate. It's not really a debate. We want to conserve as much blood as possible in the inventory, and then there's a number of studies, as you know, that show that giving patient blood, more blood is actually associated with higher morbidity and mortality. So PBM responsibilities to establish guidelines if not already in place by the institution. I don't know if we have, since I've been here 2 years, we haven't really talked about the guidelines and updating the guidelines. I just looked at the drop down, and I think because EPIC is part of the larger system, I'm sure there's a number of other people that were not involved that talk about these numbers, but I'm not aware of any kind of meeting. So if that's something you guys are interested in and looking at updated data, then the PBM committee can kind of discuss that in a journal club kind of setting. The guidelines should address indications for blood components and recommended dosing. However, obviously, we're not gonna, this is not the Gestapo or anything like that. So the medical decision is individually based, and if you want to transfuse outside guidelines, that's your right to do so. But the recommendations are there to provide guidance. So multiple factors to consider prior to transfusion. When we're looking at red cells, we're looking at the age of the patients, any pre-existing conditions such as chronic disease, especially coronary, right? It'll kind of increase the threshold to transfuse. Current diagnosis and severity, any underlying causes of anemia that may warrant blood earlier, and you might want to also consider other forms of, so other than red cells, other forms of oxygen delivery. For plasma products, like I said, the data is not as robust as red cells. As you know, the largest useful plasma is in the MTP setting, right? Massive hemorrhaging patient. The data, as you may or may not know, the units of, if you look at the average unit of plasma, the INR is, it's not 1.0. It's actually, because we use anticoagulant in the donor bank, it's actually a little higher. So some radiologist or somebody before a procedure, they give plasma, they want to chase, they look at the PTT to discharge a patient. That's a typical scenario, and it's not really working. It's likely because of the other. So PTT is not a good gauge of plasma, and even in those cases, we have other products that will help. Kcentra, any other kind of factor 7 concentrates. But also there's risk associated with giving plasma, such as allergic reactions, trolley, anaphylaxis. There was a study performed by Yang in 2012 that found little clinical use of plasma across a wide range of clinical situations, including prophylactic and therapeutic use. For platelets, we say an uncertain trigger, even though there's multiple studies to support, especially in oncology patients, that patients less than 10,000, right, should get platelet transfusion to prevent clinical bleeding. That's in a prophylactic matter for general surgeries that are invasive and lumbar punctures. We give platelets less than 50,000 and then for neurosurgery, less than 100,000. These are more or less consensus. There hasn't been like recent data to kind of to affirm these studies. So I mean, if that's something, and I think science should be performed this way, right? If something's been established over years, shouldn't we repeat the studies to see if these these things match up? However, sometimes, especially performing clinical studies, can be a little difficult in live patients, especially when we have already established protocols. So that's kind of like what we're here to. If this is some new information for you guys, we can always discuss this at our blood utilization committee about those numbers. So it's not a hard rule. So if you want to give a oncology patient, a platelet transfusion at 20,000, I mean, I wouldn't recommend it, but if that's something that you would feel comfortable with to prevent bleeding, I mean, it's outside the established guidelines, but if pathologist, our job is as a consultant, we're not going to tell you what to do. However, some blood banks, many blood banks, particularly here at Queens, we only have a limited supply. So a good steward for blood practices is to know what we have in our inventory, and with our guidance, you should kind of make an informed decision. Next is MD monitoring education. So to implement various aspects of PBM, detailed information on baseline practices are required, right, to know if we need to improve. This involves informatics, like large-scale data mining to implementing an electronic monitoring program. So these programs, they harvest data and advise clinicians. So the question is, how is the transfusion data managed and reviewed? So the transfusion data is managed and reviewed in either retrospective analysis or prospective analysis. Retrospective is after transfusion is done, we can use our laboratory information system, or we can use the EPIC or any kind of electronic health record to look at, especially in our LIS, we can look at the collection. We have the data, and that's the data that's actually presented at the blood utilization review committees, right? It's a retrospective analysis. We can see how much is used. However, we can't see clinical data. I didn't put my research when I was a resident. Me and myself and my attending, we did an informatics product. We actually used a LIS to look at the units that were distributed to the floors, and then we looked at the pre-existing hemoglobin and platelet count, and so we saw retrospectively. So we created a program. So we saw retrospectively, what those values were, which is interesting. I mean, we can gauge, say, historically, to say the doctors are transfusion appropriately or not, but we can't do that in real time. So a real time is called prospective analysis, and it's usually done through a decision support software. You might have heard these names: the clinical decision support software or the computerized physician order entry system, in which you guys use every day. This is a kind of snapshot EPIC, to make sure all the patient information is not apparent. I like this. Actually, I'm actually pleased with the way this looks. As you know, when you look at lab values, when you see an indicator, right, it's alerting you that the lab value is abnormal. You can take an action, or you may not take an action. Here, as you can see, here it's kind of blurry, but the hemoglobin in this patient is 9. And if the patient's clinically stable, you may not want to transfuse, just hold off. But however, you may not even know that. So I like the fact that the drop down allows you to actually look at indications in a kind of smart way. However, it doesn't stop you from violating the rules, or there's no way for us to see that it's violated. Of course, when you selected on the drop down, I think you are able to free text. I could be wrong, but the blood bank is also, we actually can see the indications when you guys bring the slip down to actually collect the blood. And so we can say, yeah, yes or no, it may be indicated, but we don't do that like for all the units. It's not like it's not to Gestapo or anything like that. So we do routinely take a random sample, and at the blood utilization committees, we actually talk about if any of the products that were transfused were unjustified or not, and that's more for education, but still retrospective. So ideally, and I want to get into some other institutions, software. This took one screenshot of another institutions. They have something called clinical decision support. It all depends on the EHR. So we use EPIC, and I know EPIC is very proprietary. They don't allow other softwares to integrate. But if you had a robust IT department, if they want to, I don't know if Epic, I know you can go to super Epic training to learn about Epic and see if you can actually modulate Epic. But if we were able to modulate Epic and create a red alert, we'll call this an alert, we can actually do a hard stop on any of the transfusions that may be outside the guidelines. And in this way, it does two things. It stops you from violating the rules, and it educates you, but it also gives you a chance to cancel the alert, and that stuff can be tracked. And that's what we call prospective. And so this is, for example, this is a data from another institution from a published article back in 2014, which shows the pre and post when they actually integrated this kind of support software. This shows the trends over time of about a year, and it showed the increase in alerts that were canceled. It showed the number of decrease in the total RBC orders, so the physicians are being educated and not even order RBCs when it's not necessary. And then of course the total alerts went down. And I don't want this graph to be misleading because if you look at the RBC transfusion, you might say, oh, the transfusions are roughly the same, but just know that RBCs are one of the most common procedures, especially red cells, and this could reflect, I think the authors in the paper reflected NTPs and increased activity over the past year. Similar analysis with platelet alerts. Platelets is a little bit more variable because the data, physicians have let's say a little less consensus on when to use platelets, but also the platelet variability and the number of orders could reflect NTP. So it's hard to kind of interpret that. But you can see here that the number of alerts canceled went up, and that was significant, and the total number of alerts went down. So they're learning. So it's a good way to kind of educate people and engage, practice behaviors. So, and also I didn't want to get to the cryoprecipitating platelets, but they showed similar trends. So we talked about, like I said, the retrospective analysis, prospective analysis, and then benchmarking. So once we have that data, you can benchmark, blood usage between surgeons who perform the same procedures, and can be useful in a way of changing practice habits. Like I said, we don't want to be stop. I know physicians have autonomy, but we're in the age of standardization of care. Right? This is just an example of a benchmarking. It's kind of copied from a book where it shows, for example, in this case, it will be the number of surgeons are represented by the bubbles. So we have different surgeons represented by the bubbles. They can perform any procedure, say hip replacement, let's say hip replacement. The x-axis shows the percentage total of that received the blood. So the one on the far right, he did number 9, let's say hip replacements. The one that's the largest bubble, he did 654 hip replacements. So it's the total number of cases that received at least 1 unit of blood. On the y-axis, it shows the average units of blood that was used per case. So the one at extreme right, even though he only did 9 cases, he used blood like in most of his cases in 90%, and then he gives about 2.5. So so you look at his practices, right? How busy is he? But then you look at the surgeon who's doing 654. He's utilizing the most because 40% of his cases he uses at least 1 unit. So you can kind of benchmark different surgeons, and then you can create like a threshold to say this is where we want all the surgeons to be. All right, so as far as modern education, multimodal approach, my presence here is one example, right? Grand rounds, however, studies show that grand rounds may not be as effective when you're looking for large change. That means education, but everyone receives the information a little differently. It may be meaningful to some people, and some people may be phased out, even here. So the automated alert is probably the most, I guess you'd say, it's kind of it's kind of immediate disciplinary, right? I'm sure in pharmacy, if you order a patient drug and you give them another drug that may, interact, it'll give alert, right? In Epic, and so in a sense, having an alert for transfusion is kind of like in a similar manner. Informal discussions, I like having conversations offline, like with residents and medical students. Those are my favorite because they're very impressionable, and they're the future leaders, and so informing them and the house staff about evidence-based practices, or rather, they'll come to me and say, oh, my attending did this or that, and I never want to overstep boundaries, but I can give them up-to-date information. And then speaking with attendings is actually equally as meaningful. But however, I'm definitely don't want to insult anybody's practices. That's not what pathologists do. We're here consultants, and we are based on evidence, based on science. So providing a consistent message about transfusion threshold, waste reduction strategies, and techniques to avoid transfusion optimal effects of PBM can be realized. All right, so let's go into preoperative hemoglobin management. And this is actually the domain I am probably the most confident that you guys are already doing here at Queens and most hospitals, and we obviously, you're in medicine. So I'm sure you're addressing the anemia, but the question is, do you guys have an established algorithm for dealing with anemic patients before surgery? I'm sure you're addressing it, but it's like there's a protocol. So as you know, the WHO defines anemia as less than 13 grams per deciliter for men and less than 12.5 for women. Studies show that preoperative anemia is common in surgical patients, which has a wide range, right? Depends on the type of patient, pre-existing conditions, about 5 to 75%. Also depends on depending on the obviously patient age, comorbidities, gender, and so forth, and the type of surgeon. Preoperative anemia has been associated with increased morbidity and mortality in surgical patients. So there was a couple studies that were done. These are older studies, however still relevant. Back in Transfusion Journal in 2002, there was a retrospective study about 2,000 patients who refused blood and they underwent non-cardiac surgery. Studies show that perioperative mortality was significantly increased when the preoperative hemoglobin was less than 10. And then another study a few years after that by Wood and his crew in JAMA. There was another retrospective study in VA patients, about 30,000 of them over 65 years of age, and it showed that the post-operative hemoglobin after surgery fell 30%. So the take-home message from these two studies in conjunction is that patients they will have anemia right after surgery, right? It's one of those things, especially if there's blood loss, and that the perioperative transfusion would be necessary. So if you don't address the preoperative anemia, it's associated with higher risk of morbidity and mortality, and because the patient will be bleeding. That's the take home. So the PBM goals and domains to manage the anemia. PBM programs have been developed to identify patients undergoing elective surgery 2 to 4 weeks prior. So I don't know if there's established protocol here as far as when is the optimal time frame to address before surgery. But standard is 2 to 4 weeks prior to the surgery, and then performing the screening hemoglobin. I won't get into medications because I don't prescribe. So I just want to mention that there's oral iron, and it's definitely not expensive at all. There's IV iron formulations that are becoming more safer, right? Especially after the heavy dextrose have kind of dwindled down. And then there's the ESAs, such as point alpha, double point alpha. I'm sure you guys are familiar with these drugs. So next domain is the reduction of preoperative auto donation. That's the way to conserve blood. But you may ask, why don't we do auto donation to save blood? I'll get to that. Listen to this. So autologous blood donation is the donation of 1 or more units of one's own blood, usually in the preoperative setting. Like I said, this interest rose in the 80s and 90s because of concern of transfusion transmitted infections. However, since that time, auto donations have been in decline, and we actively discourage that because we have improved biomarkers for testing, right? It has a smaller or narrow window period, right, for hepatitis B, C, HIV, and so forth, all the infection that we test for donor blood. Also, recognition of high cost, right, in procuring the autologous donor. So you have to bring the donor in, you have to deal with bags and everything like that, so it's a higher cost. There's also increased wastage. So if you collect the blood, and if you don't use it, it gets thrown away, versus, we have the blood in the blood bank allogeneically available. So if you don't need it, it can be used for another patient. Autologous blood, you can. Increased risk of adverse affections. So you may ask, adverse why? It's not the fact that they're receiving The blood is actually the donor itself. So when you're giving autologous, you're just not giving autologous, but you're a donor now. And so these patients are not the healthiest, and so you may either introduce, I mean, you're probably aware that you're introducing possibly iatrogenic anemia, but also the adverse reaction that any donor can undergo, vasovagal, any kind of cardiac issue, especially pre-existing. The donors can have nerve injury. You can actually puncture an artery because we're using a larger bore needle and so forth. And also PB implementation. I said, I just highlighted that because just introducing those concepts of conservative measures causes people to not even consider autologous donations anymore. I don't think it's actually, the only reason I would even consider autologous donation or directed donations, and directed donations are from family or somebody that the recipient knows, is if the patient has a rare blood type or has multiple antibodies that are difficult to match, right? Just wanted to show you, this is a graph over the years, sharp, steep decline. It's basically nil. Next is cell salvage, intraoperative and postoperative cell salvage. Cell salvage is the process of collecting shed autologous blood, its processing, and its re-administration. It takes place in the intraoperative period or in the postoperative period, the different forms. This is an unwashed cell salvage device used for a knee replacement. I don't know if you guys have seen this before, but I have not seen this device in real life because I'm not by the bedside often, so I don't know if it's used consistently here. The question is it worth it, right? If doctors do use it, because if it's estimated, especially in surgeries, because it's only, especially in these unwashed devices, they're only going to take a certain amount, only collect roughly a unit or two of blood, and if we know that the patient's going to bleed anyway, that blood that's salvaged is going to be diluted, right? And so we're only saving roughly 20-30% of that packed volume. So optimally, just give the patient a unit from a blood bank versus the unwashed device. And also, the reason I don't encourage unwashed cell salvage devices is because we're not really leuko reducing. We leuko reduce most of our products, platelets and red cells, to prevent febrile reactions due to the biological response modifiers. And if you don't wash the products in those surgeries, then you can have some febrile reaction. This is a washed cell salvage device, and I'm very familiar with this. I'm sure you guys seen it. When you guys order cell salvage, in which you guys do at this hospital, it's kind of something we kind of monitor here at Queensland Blood Bank. We actually utilize New York Blood Center for that practice, because we don't have an in-house like we call it perfusionist or anything like that actually has ownership over that. Although we could, if it's something that we do more often. I know some institutions use cell salvage more often on a frequent basis, but we don't do that. We don't do a lot. We probably have 4 or 5 cases every quarter, so it's not highly used. But this is a wash device. As you can see here, like I said, when blood is collected from the patient, and the reservoir here is suctioned up into the centrifuge. Centrifuge, it spins it down, forms a packed gradient. Right, you have the plasma on top, packed cells at the bottom. Salines or lactate ringers is introduced to mix it, and then the waste bag is here. So the waste bag is once it's been washed, and then it's returned to the patient. So once it's returned to the patient, it's just it's packed cells in addition with anticoagulant. In addition, so after we collect the blood, and it's in the anticoagulant, we leuko reduce. So the product is leuko reduced, is washed, and compared with the unwashed device, right? It's not leuko reduced and it's not washed. So washing is performed, like I said, with the isotonic solution to prevent red cell lysis. The reinfusion bag should never be directly connected to the patient. I don't know if you guys seen blood that's actually procured, right? But they burp the bag sometimes to prevent blood from being potential embolism. And also, I would recommend, like I said, I'm speaking to the crowd here, but if we do have in-house perfusionists, I would recommend efficiency as far as like regulating the suction, right? So you won't have to damage the cells, and then washing the bloody surgical sponges to maximize blood recovery. So what are the indications and feasibility? It all depends on the anticipated blood loss, financial status of institution, provider preferences, and then there are multiple contraindications, such as using hypotonic solutions, hemostatic agents, heavy metals. And I put a question mark by the amniotic fluid contamination, malignant surgery, and dirty surgery, because even though it's almost intuitive, right, to actually use cell salvage in those situations, the studies don't support, like you might think, you say malignant, so patient has a cancer, it doesn't preclude you from actually using cell salvage. You might, wouldn't you see, the metastatic cells into another part of the body? Studies show that doesn't happen. It was not the case. So even a dirty surgery, studies show, because we wash it and leukoreduce, studies show that patients don't get sepsis due to that procedure. So very interesting. However, I know providers prefer not to use it in those cases. Next domain is intraoperative normovolemic hemodilution. I spoke with a couple of anesthesiologists at Elmhurst, and they don't use that. They're not familiar with that at all. I don't know if it's a common practice anymore, or maybe some institutions that may be familiar. I don't know what's the activity, the frequency, but normovolemic hemodilution is basically when you phlebotomize a patient from an arterial or venous line. The catheter is generally done shortly before the surgery, and shortly obviously before the anesthesiology. We generally collect about a unit, and in the standard donor bag, we give anticoagulant in that blood, so it's kind of left at the patient's bedside. And there might be multiple units, 1 or 2 units, and when it's reinfused, or before it's reinfused, the patient is administered also normal saline, so they have diluted blood, right, in their system. And so the anticipation is that the patient will bleed, and if they do bleed, it will be more diluted blood versus their own cells. And when we give back the phlebotomized products, it's done in a reverse order. The whole goal of that is to actually, the reverse order is just preserve coagulation, right? The coagulation, obviously it starts to degenerate, right, immediately after you collect, especially when it's held at room temperature. So we give, it's kind of last out, first in approach. So it's a technique intended to decrease and minimize the need for allogeneic transfusion. However, I don't know if it's kind of standard practice, so I'll just kind of jump ahead. Next is intraoperative hemostatic agents. I want to spend a little time on this because I'm not a pharmacist, but I just kind of want to discuss these alternative solvent detergent plasma, prothrombin concentrates, antifibrinolytics, desmopressin, fibrinogen concentrates, and then recombinant activator 7. So solvent detergent plasma, you may have or may not have heard of this. It's a product that's manufactured from plasma pools, about 600, 1,500 donors. It's ultra filtered and subjugated to solvent detergent treatment for about 1 hour. These are done at plasma centers, right? We have a donor center, and then we have plasma center. I don't know if you ever donated your plasma for money. There are centers available for that. They actually create albumin, IVIG, the other products, and then a human derived. So all their products goes through this kind of process of inactivation to prevent any kind of contaminant. However, it doesn't really get rid of HAV and parvovirus very well. However, there's screening process available to prevent those bugs from being introduced into the products. So the premier, I guess you say, company called Octoplast, and actually the product's Octoplast, the company is Octapharma. They actually campaign very aggressively. I actually spoke to a lady last week for Octoplast, trying to sell it, right? It looks like plasma, smells like plasma. For most physicians, you'll see it hanging. It's maintained in the same storage situations as standard plasma. However, it does have lower levels of protein S or alpha-2 antiplasmin. However, I'm not really convinced. I want to just introduce you to the product, but you're not going to see it at Queens anytime soon. I guess you could say there was a small wave about 10 years ago because it's pool, they reported lower incidences of trolley, right? Trolley, the pathogenesis that there's donor antibodies, where the donor antibody is causing well, actually, donor antibodies reacting in the pulmonary capillary bed in patients performing an exudate. So, when we have this pool, even if a patient, a donor may have anti-HLA antibodies, because it's pooled, it will be diluted. So that's what they mainly purport, and we kind of, transfusion medicine physicians in the beginning, we were like, oh, this is kind of, that's nice. But then, because Trolley is so rare, it's all about, is it worth it or not? Next is the prothrombin complex concentrates. We have the 3-factor and 4-factor. You may or not even, I don't want to spend much time on the 3-factor because it's not as popular as the 4-factor, which contains factor 2, 7, 9 to 10. As we know, this has case central. It's FDA approved. It's used for urgent vitamin K antagonist reversal, but physicians use it for other indications as well. It's performed, the studies as far as other settings are not as robust. However, I'm not going to fight any physician that want to give case central over plasma because it's been around for a while. It's kind of, it's dependable. So I'd rather save our own plasma, use it for MTPs, hemorrhaging patients versus patients that are stable. But I know also case central has been introduced in the NTP protocol as an additional supplement, and I'm not going to fight that as well. Next is antifibrinolytics. I don't have much experience with these agents, tranexamic acid and epsilon aminocaproic acid. They are lysine analogs. They inhibit plasminogen to its active form plasma, therefore having this antifibrinolytic effect. The main study, it's called CRASH-2, it involved 200,000 adult patients, and the all-cause mortality using tranexamic acid exclusively in the tranexamic arm versus placebo was that there was reduced death due to bleeding. However, there was no difference in bleeding or number of transfusions, which is, I just take a look at the paper. I spent some time reading it. So they report that the greatest benefit using TXA was, in the trauma setting, if they're given less than 1 hour after injury, our patients still bled. However, the cause of death were reduced. Was the number of deaths that were reduced were the deaths due to bleeding, which I find that interesting. I looked in discussion, and so they didn't explain why. They didn't have no reason. We don't know why it happened, but I'm guessing maybe the cause of the bleeding is the case here. So the patients have reduced death because they had maybe less internal bleeding of vital organs. But just take a look at this paper. I don't know if there's interest in instituting TXA in the trauma protocol here at Elmhurst, but I know some institutions have TXA, especially if they're in pre-hospital settings, right? Some hospitals even keep units, of packed cells in the helicopter, platelets, and TXA, so it could have some role. But, recent studies, these previous studies back in 2010, recent studies have not been, forthcoming, so I find that interesting. Desmopressin is available. I won't talk much about it. DDAVP, I don't know if you guys give that. I'm sure you've maybe as an alternative, patients who have von Willebrand. I know we have concentrates for von Willebrand, factor VIII, so it may not be as much used, but it is an alternative if those products are not available. And then for fibrinogen concentrates, the two major, companies are Riostab and Fabrica. So I added Fabrica yesterday. Like I said, I had a pharmaceutical agent actually kind of let me know that it's available. So Riostab is probably more common. Like I said, we order these products if you guys need it from New York Blood Center. They provide and they order it when needed. So we haven't gotten these orders. I spoke to our manager at Elmhurst. We haven't gotten these orders as of late, but if you guys need it, we can obtain it. So the fibrinogen concentrate, similar to the TXA, it's kind of like they have roles, right? Especially in the trauma settings, or especially during surgeries. You want to, instead of giving plasma, however, it's not cheap. And the question is it worth it, right? You give the ideal dose is 2 to 4 grams, and it's ideally supposed to replace 4 to 5 units of cryoprecipitate. But cryoprecipitate is still available. It's concentrated, right? And we have enough cryoprecipitate. They're not flying off the shelves in the blood bank. So why pay more money, right, to use fibrinogen concentrate? But I'm sure there's a role. So the question is, when we talk, and so I'm kind of sidebarring a little bit because I talk about patient blood management. This is still patient blood management. Question is it worth it, right? You spend money, you try to conserve blood, but you got to look at the cost. Is it worth the strategy? All right, so I'm gonna speed up a little bit more. This recombinant activated 7 is also available. I won't go into that. Next is point of care testing. As you know, point of care testing is not a new concept to everybody in this room. It involves placement of laboratory equipment near or at the patient bedside. Despite what you think, even point of care testing is still under the jurisdiction of general laboratory. However, we do give providers kind of autonomy and the role of using it. However, upkeep is still a responsibility of the main laboratory because these products are not they're not definitive, right? They're not as accurate as the central laboratory test. Like I said, we have different, as you know by now, there's all kinds of different analytes you can analyze in point of care testing. Even blood bank has point of care devices in the form of hemobank having blood available on the bedside. So point of care testing is not new. However, so we know it's purported to have increased turnaround time, that gives physicians more time to make informed decision. You can do microsampling with point of care testing instead of drawing a whole unit, whole vial of blood, right? Which I find that great in preventing iatrogenic anemia. The disadvantage, as I mentioned, is the methodology, because it's different in the central laboratory. So PBM programs, we have TEG, we have ROTAM. It's becoming more popular. I don't know if it's used as often here as TEG. It's like most point of care testing, pathologists can't see that in real time. We can look retrospectively and see the data. However, we can't make the TEG and ROTAM only exists for the physician to make informed decisions. So the idea with the ROTAM and TEG and patient blood management is that if you use the blood, you can use it more smartly. And then the last component is the minimization of phlebotomy, right? Kind of alluded to that in the point of care testing, right? Repetitive phlebotomy, especially certain patient populations, right? It's definitely at the fault of our own. So you can look at the numbers here, in a healthy patient like me and you, over a number of days, if we're routinely drawing only a small amount of blood, 53 mils over a number of days, we can become an anemia patient. So if you can consider the ICU patient, the average hemoglobin is definitely lower than healthy patients. They can definitely reach that anemic level and below really, really quick. So just be cognizant. And so there are different ways. So the PBM goal is to develop measures to limit that. So you look at this, you did it the CBC one day and you saw the H&H, or if you do a CBC, you do a KIM panel one day, the next day is the whole CBC necessary? If the hemoglobin is low, or can you just do an H&H, right? And I said this for years, and I don't know if it's routinely practiced and people don't think about it, but even using PD tubes, for an ICU patient, just for checking an H&H would be, I think, it's not a crazy ask, right? But I don't know if the buy-in from the hospital should be there, I don't know if that's practiced here, but maybe that's something. And I think that's probably the most feasible things that, as far as PBM components, that's probably the most feasible thing we can achieve. And one of the most actionable things, and as far as research projects, one of the residents or fellows can potentially do that. Sorry to cut it short, like I said, so I want to stop right now. So in conclusion, PBM is a growing critical domain within transfusion medicine. The tenets and components, they can never be stagnant. As paradigms of medicine and how medicine's practice continues to evolve. The PBM program can be compartmentalized into potential clinical and research focused areas where the transfusion medicine physician or physicians in any discipline can perform projects. And that's why I introduce the components often in my meetings, because it's kind of a revolving door. We can always consider and do potential projects. I'm sure, especially in attendance, I'm sure you're dying to do something. So call me up, and then we can tag team or something. So PBM, so it requires, like I said, I can't make a program on my own. I will need some champions, definitely IT support, institution top-down support. But at the end of the day, if the PBM program is established, like I said, it can definitely lead to cost savings to the institution, but optimally it is the patient care, right? Quality, standardization, patient care, especially in those institutions who already have established programs. And then if another institution sits by and not even think about it, it's like antimicrobial stewardship. If you don't even think about it, why? That means you're not achieving the best care. It's not standard. All right, this is kind of a screenshot of the certificate that's on the Joint Commission website. They have a number of hospital certifications they give out, and the PBM certification is one of them, right? And where you review the standards at your own time, see what it takes to have a program. All right, and these are the references that are not added to the slides. Any questions?